Hello everyone, welcome back to your lecture series on overview and integration of cellular metabolism. We are studying heme metabolism and this is the second class where we will be discussing the disorders of heme synthesis or porphyrias. Alright. So, the concepts that we will be covering today are the pathway of heme synthesis that you already know, we will be revising that, the defects in the enzymes that are there in pathway of heme synthesis that leads to these diseases known as porphyrias. What are the types and varieties of porphyrias, what are the symptoms, how we can diagnose and how we can treat them, everything we will be covering in this lecture. Now, you all remember, right, from the last class of heme synthesis how the initial two products succinyl coenzyme A and glycine was combining to form delta amino levulinic acid, okay, del ALA, okay, delta amino levulinic acid. This is the sign of delta, right. And in the next step we discussed how two molecules of delta amino levulinic acid were combining to form one molecule of porphobilinogen, right. But in reality we discussed that 4 of these porphobilinogen will be required. So, in total 8 ALA are needed. So, first it forms a porphobilinogen which forms a linear tetrapyrrole. This is not yet circular, I mean this is not, the ring is not closed, which is also known as hydroxymethylbilane, alright. Thereafter it transforms into uroporphyrinogen 3, alright, which again transforms into coproporphyrinogen 3, then it converts to protoporphyrinogen 9, then it converts to protoporphyrin 9 and finally with the help of iron it converts to heme, alright. So, most of you who have already gone through that class, I hope you have easily remembered the steps. If not, this is a very good way to remember it. Okay, if you are having if you are struggling in remembering, I have got a very good mnemonic for you. The mnemonic states that some good doctors prefer hugs under cover produces perfect healing, alright. So, I have given an illustration diagram and this concept is actually very important where a doctor hugs his patient. It has been depicted in many Bollywood movies, Munna Bhai MBBS for example, Jadoo Ki Jappi. But the thing is, if you can just relate this mnemonic and the initials, you can easily remember that the products that are coming in succession in one another, right. So, succinyl CoA, glycine, delta amino levulinic acid or ALA, then porphobilinogen, first linear tetrapyrrole hydroxymethylbilane, uroporphyrinogen 3, coproporphyrinogen 3, protoporphyrinogen 9, then protoporphyrin 9 followed by heme. Okay. It is a very good way to remember if you are struggling, okay. But if you have been able to memorize and remember, I applaud you, right. Not only the products you have to remember, but you will also have to remember the enzymes that were catalyzing the reactions. The first enzyme is ALA synthase that helps in combination of succinyl CoA and glycine, right. Thereafter ALA dehydratase, hydroxymethylbilane synthase is also known as porphobilinogen deaminase. This enzyme has got multiple name or even uroporphyrinogen 1 synthase, right. Thereafter, uroporphyrinogen synthase is also known as co-synthase, right. Then decarboxylase, 2-oxidase enzyme and last enzyme is ferrochelatase. So, is there any way to remember this as well, right? There is, right. So, I give you another mnemonic. Aunt Alice has unusually useful crafting powers, friend, right. So, remember magician Aunt Alice who can craft many things by waving her magic wand, right. So, you can again see the initials of this mnemonic corresponds to the enzymes, right. So, why we are stressing so much in remembering all of these products in sequence and all of the enzymes? Because this is very important. I told you in any metabolic disorder, what we will be studying today is the disorder of these enzymes, right. So, any enzyme if it gets deficient or it has got low activity, what I told you, the product before that will get accumulated and the product after that will be deficient. This is the basic rule of any metabolism. So, unless you know what comes after another in sequence, it will be very difficult for you to conceptually write the answers, right. If you can just memorize, but then again there are so many things to memorize, so many cycles, it will be very difficult, challenging, right. Nothing is impossible with a lot of hard work and writing habit. Anyway, so the disorder, coming to the disorders of heme synthesis, so this was all about last class's revision, right. I hope you have gone through them very well. So, coming to the disorders of heme synthesis, they are collectively known as porphyrias, all right. So, disorders associated with biosynthesis of heme. What is the reason? Basically, we all know the enzymes are proteins that are coded by genes that are designed for those proteins, right. And if there is some mutation in those genes, the enzyme activity will be improper, it will be reduced, and that will lead to these diseases. So, all of the enzyme of heme synthesis leads to some or the other porphyrias, okay, and the problem is in mutation. So, what is the generalized characteristic? Basically, increased production and excretion of porphyrins or their precursors. For example, so if we are calling the porphyrin, we already know what are porphyrins, and the precursors mean ALA and porphobilinogen. I already told you before porphobilinogen is formed, right. So, delta aminolevulinic acid and porphobilinogen are the precursors, right. How are they inherited? Most of the porphyrias are inherited as autosomal dominant, AD, very important, all right. So, can we classify the porphyrias? Yes, depending on the symptoms, depending on the metabolic pattern, they can be classified, right. They can be broadly divided into hepatic porphyrias, erythropoietic porphyrias, and a mixed variety, basically some porphyria which has got both erythropoietic and hepatic abnormality. Okay. There are some other ways the porphyria can be classified: congenital or acquired, acute or chronic. Okay. Even some porphyrias are also called cutaneous porphyrias and non-cutaneous porphyrias. So, depending on your textbook, it can be, or depending on the presentation of the patient, it can be classified in many ways. We will be discussing everything. So, this is the pathway, but now you already know the compounds that are appearing sequentially, and you already know the name of the enzymes with the help of two beautiful mnemonics, right. But then again, you need to remember the diseases that are caused by deficiency of these enzymes. Okay. So, the first important name that we need to remember is acute intermittent porphyria. It is caused due to the deficiency of the enzyme porphobilinogen deaminase or hydroxymethylbilane synthase, HMB synthase, same enzyme HMB synthase, the same enzyme deficiency leads to acute intermittent porphyria, followed by congenital erythropoietic porphyria due to the deficiency of uroporphyrinogen 3 co-synthase. The next name that you need to remember due to the deficiency of uroporphyrinogen decarboxylase is Porphyria cutanea tarda, abbreviated as PCT. All of these have got abbreviation. This is AIP, this is CEP. Okay. Hereditary coproporphyria due to deficiency of coproporphyrinogen oxidase, variegate porphyria or porphyria variegata, okay, due to deficiency of protoporphyrinogen oxidase, and finally the deficiency of heme synthase or ferrochelatase. Ferrochelatase deficiency leads to hereditary protoporphyria or erythropoietic protoporphyria. The name protoporphyria is very important, all right. So, again there are a lot of names that you need to remember. Well, you can remember them by memorizing this phrase: all congenital porphyria have variable presentations. Okay. Presentations, right. So, how does it help you to remember? Acute intermittent porphyria, congenital erythropoietic porphyria, porphyria cutanea tarda, hereditary coproporphyria, variegate and protoporphyria. alright. So, all congenital porphyria have variable presentation. This is a phrase, a mnemonic by which again you can remember the names, right. So, there is a lot of memorization that you need to do, and these are the keys by which you can take the help of these keys to memorize them in sequence. Okay. The first two enzymes that I did not mention are not that much important. These are the ones that are most common, the 6 varieties of porphyria. However, there are two enzymes, the enzyme before hydroxymethylbilane synthase, that is the rate, I mean this enzyme ALA dehydratase. The deficiency of this enzyme leads to ALA dehydratase porphyria or DOS porphyria. It is very rare. Till date, less than 10 cases in the whole world has been reported. So, you can, upon billions and billions of population, only less than 10 cases have been reported. It is not 10 in 100 or 10 in a million, it is total 10 till date in world population, right. So, it is very rare. So, we do not consider it as a thing to be worried about while diagnosing the disease. Why we are studying the whole course? Because we are making ourselves proficient enough so that we can diagnose the most common disorders, right. One goal of this course is definitely that. And the first enzyme, that is ALA synthase, right. The deficiency of that enzyme does not lead to porphyria at all. It leads to a disease that is known as X-linked sideroblastic anemia, all right. So, we are calling about, I mean talking about deficiency of all the enzymes. The deficiency of all of these enzymes produces some form or the other of porphyria. This is a very rare ALA dehydratase, therefore, we do not consider it at all, and ALA synthase deficiency does not produce porphyria. However, one very important thing to note, and you also probably remember what I told you in the last class, that once heme is synthesized, it actually inhibits its own production by inhibiting the feedback, I mean by means of feedback inhibition, it influences the enzyme ALA synthase. This is the rate limiting enzyme, right. So, if somehow there is a situation where, so once we have heme, the production of more and more heme, when the required amount is reached, it is not, I mean the excess heme is not produced, therefore, excess degradation product is not a thing to worry about normally. But if due to some reason the inhibition of heme on the rate limiting enzyme is lost, right, or if there is a situation where the activity of this enzyme is actually increased due to some reason, then there will be a problem. Then there will be a problem that all of these products will be produced more and more, and that is exactly the problem when there is a specific disease that is known as X-linked dominant protoporphyria. Mind it, X-linked dominant protoporphyria, where we are not dealing with any deficiency, but we are dealing with a gain of function mutation. A mutation happens due to which this have been reported very recently, right. So, in older edition textbooks, this disease might not even be documented, right. So, a gain of mutation function leads to an excess production of all of these products, right. So, all of these products will be excreted in urine, and it will lead to a common symptom that we will be discussing very soon. And moreover, this has been found due to a gain of mutation of ALA synthase 2, right, which is actually present in erythrocytes, erythroid variety, which has no effect of heme as a feedback inhibition. So, all of this phenomena leads to a peculiar disease which is also very rare, but gain of mutation function, and the name of the disease is X-linked dominant protoporphyria, and as you have guessed by now, the inheritance is X-linked dominant, right, sex chromosome, not autosomal, unlike the other porphyrias. So, let us discuss the first important porphyria, that is acute intermittent porphyria. This is the stage where this enzyme is inhibited. So, there will be no synthesis of uroporphyrinogen 3, right. So, porphobilinogen. So, after porphobilinogen there was synthesis of hydroxymethylbilane, right. So, basically hydroxymethylbilane synthesis will be hampered, right, not porphobilinogen, not urobilinogen. So, this will not be synthesized. So, deficiency of the enzyme hydroxymethylbilane synthase or porphobilinogen deaminase, which is coded by the HMBS gene. Remember, hydroxymethylbilane synthase is the newer name and uroporphyrinogen 1 synthase was actually the older name. Porphobilinogen deaminase, uroporphyrinogen 1 synthase, these are all older names. Hydroxymethylbilane synthase is the newer name. The linear tetrapyrrole was named hydroxymethylbilane much later compared to when the whole synthesis was discovered, right. So, what happens? Naturally the previous products, that is delta aminolevulinic acid and porphobilinogen level will rise, all right, and since heme synthesis is not happening, ultimately since if there is a block here, the heme synthesis will not happen, right, and therefore the inhibition of the previous enzymes due to feedback inhibition will not happen. Therefore, a secondary increase in activity of ALA synthase is happening because the end product inhibition is not effective, right. So, this is the basic pathology of the disease, which is known as acute intermittent porphyria, AIP. So, why it is named acute intermittent, right? Acute because of the symptoms, intermittent also because of the symptoms. Patients present with vague symptoms which are intermittent, it happens time after time, okay, it will not happen continuously, right. And what is the symptoms? Acute abdominal pain, that is the most common symptom of acute intermittent porphyria. Patient will present with excruciating pain abdomen, right, and this is one of the medical reason of pain abdomen. Mind it, in medical science there are multiple reasons of pain abdomen. For example, even now you can probably enlist multiple reasons of pain abdomen, for example, problem in gallbladder, appendix, stomach, pancreas, so on. So, there are multiple organs where there might be some defect and that can lead to pain abdomen, but this is a medical reason where there is a problem in metabolism and presents with acute pain abdomen. So, there is no defect in any organ. Most common investigation, ultrasonography, whole abdomen, that is prescribed to any patient with pain abdomen will be absolutely normal, X-ray abdomen absolutely normal. So, there it will raise the suspicion for uncommon diagnosis like acute intermittent porphyria. Of course, there need to be other family history, genetic predisposition, etc. So, apart from abdominal pain, there might be another group of patient that will present with neurological manifestation, for example, motor disturbances, confusion, agitation. You already know what are the neurological signs, right, from other previous amino acid metabolism disorders, but generally since these are not strictly speaking amino acidureas that help in brain development, right, mental retardation is not a phenomena in these type of inherited disorders. Mind it, these deficiencies are also enzyme deficiency, gene deficiency, it is actually present in your gene. So, it may or manifest even since birth, right, but there is no problem in mental retardation. Other neurological phenomena that leads to excess triggering of nerves and cardiovascular system vasomotor symptoms like tachycardia, vomiting and hypertension are very common. So, abdominal pain, neurological manifestation, vomiting, tachycardia, high blood pressure, very common, right. Also, some patients may have psychiatric problems, okay, and they need to be treated accordingly. It has been seen that women have less severe manifestation before menarche, right, before the menstruation starts, they do not present with any symptom, or after menopause, but during active menstrual phase of their life the disease presents, right. So, there have been research articles that have tried to document gained inference that female sex hormone have a stimulatory effect on the rate limiting enzyme, that is ALA synthase, right. It is because we are having activity of ALA synthase, therefore, when ultimately the block is there, the products will accumulate. Okay. So, what are the mechanism of these symptoms? How a simple block in the enzyme hydroxymethylbilane synthase leading to all these symptoms? So, let us understand. First of all, the exact mechanism of acute attack is not clear yet to date, it still is a matter of research interest. However, scientists have been able to pinpoint several reasons. Number one being the building up of those intermediates, toxic intermediates like porphobilinogen leads to a effect of neurons, that leads to nerve conduction defect, and more specifically the autonomic and peripheral nervous systems are more vulnerable because the brain is protected by the blood brain barrier, right, and these porphobilinogens actually cannot cross the blood brain barrier, and therefore they have much less central CNS effect. The more effects are peripheral nervous system, autonomic nervous system. So, pain, abdomen, the nerves that are in the outside the brain, right, same tachycardia also due to same triggering of a nerve in the periphery, right, vagus nerve. Minded, all the nerves that are outside brain are known as peripheral nerves, and the brain and the spinal cord are central nervous system. Among them, the brain is actually protected by the blood brain barrier. This is the basic physiology. So, explanation of the findings such as abdominal pain and tachycardia are mainly attributed to the nerve conduction defect caused by the accumulation of toxic porphyrins, right. And the toxicity may be so progressed in some cases that it may also lead to paralysis. Okay. How it is inherited, I already told you, autosomal dominant, right. However, there is something known as gene penetration, right. Mind it, in autosomal dominant variety, the enzyme is actually not fully absent, generally there is 50% defect enzyme activity that is hampered, but even then everyone who has got HMBS gene mutation does not have the disease, even if it is autosomal dominant. Mind it, autosomal dominant means it will get transmitted generation after generation, but there is something called penetration in which even if the gene is present, only 10% of the cases have been found to have the disease. Penetration means the genotype actually expressing as a phenotype, that is the probability in rough words, right, that is the gist of it. So, therefore, not only the role of the gene, but there are other modifying factors, for example, maybe environmental factors that have been speculated to be a mechanism behind these acute attacks, right. Very important thing, urine is actually colorless when it is voided, right. However, urine on standing, urine has got porphobilinogen, right, but the porphobilinogen is colorless. Upon standing, it will form reddish color due to conversion into porphobilin, right, but porphobilin is not present in blood, right, porphobilin will come much later in the pathway. Porphobilinogen, so urine is colorless to start, during voiding it will become dark colored upon standing, right. So, urine samples for porphobilinogen estimation should be freshly collected and transported in dark bottle, because light helps in transformation of porphobilinogen to porphobilin. So, how it can be diagnosed? Ehrlich's aldehyde test is used to confirm the diagnosis of acute intermittent porphyria. So, this is very important, the name of this test. Okay. We will be again discussing the mechanism of this test later. So, distinguishing feature of acute intermittent porphyria, how it is differentiated from other varieties of porphyria, is there is no, there is absence of any photosensitive cutaneous symptoms, right, in addition to acute attack. There is only acute abdominal pain, tachycardia, vomiting, but there is no photosensitivity. We will be discussing in detail what is photosensitivity, why you are saying there is no photosensitivity. It means there will be other varieties of porphyrias that do have photosensitivity, all right. So, drugs like barbiturate, which are known to induce allosynthes, can precipitate the attack. Definitely allosynthes is an enzyme that helps in more and more synthesis of hydroxymethylbutyl rate limiting enzyme. So, drugs that are inducing the enzyme will increase the attack, right. It is also precipitated by starvation and symptoms that are starvation, that is hypoglycemia, right, and it is relieved by high carbohydrate diet. Why it is so? I already discussed during heme synthesis regulation that higher cellular concentration of glucose prevents induction of allosynthase. So, somehow heme synthesis is inhibited when there is more glucose. That is the reason why glucose infusion is actually a mode of treatment to alleviate the acute attack. Moreover, other inhibitors of ALA synthase like hematin and heme arginate are also treatment of choice during an acute attack, right. So, we already discussed the reason of X-linked sideroblastic anemia, that is deficiency. Gain of mutation in ALA synthase 2 leads to protoporphyria, which is X-linked dominant, right. This is very rare, and this we have discussed before hydroxymethylbilane. Okay. Now, after hydroxymethylbilane, all the products, okay, all of the diseases that comes after hydroxymethylbilane have got a feature of photosensitivity. Why? Because the products formed due to block of the corresponding enzymes, they get converted to toxins, right, and they have got a specific mechanism of action. So, the next disease that we need to study is, which is happening due to deficiency of uroporphyrinogen 3 co-synthase, is congenital erythropoietic porphyria. So, what is happening in that? Defect in uroporphyrinogen 3 co-synthase inherited in autosomal recessive, very important MCQ exception. Okay. Photosensitivity is a major manifestation, okay. Due to presence of porphyrins, the intermediates gets converted to porphyrins in the capillaries. This porphyrins actually absorbed ultraviolet light and they get excited and they generate free radicals or reactive oxygen species, which actually destroys lysosomes. Lysosomes contain lytic enzymes, digestive enzymes. So, once these lysosomes are damaged, these are released into the system, and mainly the reason where there is most UV, that is the skin, it leads to destruction of the skin, in some cases also hemolysis. So, cutaneous destruction, that is the reason where UV ray, if it strikes the skin, it leads to damage of the skin. And repeated attack of this dermatitis, healing, again getting lesion, it leads to scarring, and since face is one of the area where it is most exposed, the face becomes deformed and it is known as monkey skin. You can see a dreaded face of congenital erythropoietic porphyria, very tough to cope up with these sort of patient, and the patients who have got this disease has got a very difficult life to live with, right. Repeated ulceration and scarring may cause mutilation of nose ear cartilage, that may mimic leprosy, right. And in some cases UV light, right, when reflected onto a teeth, a red fluorescence is seen due to presence of these porphyrins, it is also known as erythrodontia. Okay. So, you can see red teeth, right. The next disease that we are studying is Porphyria cutanea tarda. So, now you can just remember the names. Now, it is very easy, you can just remember what are the things that are getting blocked, what are the stuffs that are getting accumulated. Okay. So, I will be just breezing through the slides and you will be able to easily relate on your own. So, hepatic autosomal dominant and most common porphyria, okay, Porphyria cutanea tarda, an MCQ question, caused by partial deficiency of uroporphyrinogen decarboxylase, okay, which is involved in the conversion of uroporphyrinogen 3 to coproporphyrinogen 3, right. Next, what happens? Uroporphyrinogen 1 and 3 and porphobilinogen are excreted in urine, that leads to a production of a already dark colored urine, port wine stain, okay, and urine becomes pinkish to brown, it appears pinkish to brown. Clinical symptoms are photosensitivity, a common thing, and appears during 4 to 6 decades of life, so in elder patient 40 to 60. And hepatocellular damage and alcoholism is characteristic of this condition, right. Hepatocellular damage, already liver is getting assaulted due to alcohol, and in presence of Porphyria cutanea tarda, hepatocellular damage is again triggered, and that leads to ineffective erythropoiesis, which is a symptom of this disease. So, this is the cutaneous symptom of Porphyria cutanea tarda, right, due to photosensitivity, again excess scarring. Next, hereditary coproporphyria. Due to deficiency of coproporphyrinogen 3 oxidase, the corresponding products that are excreted in urine is porphobilinogen and coproporphyrinogen 3, right. It is also excreted in feces. Urine again red colored due to same presence of pigment and fecal excretion of urine coproporphyrinogen is more. Clinical symptom photosensitivity, right. And sometimes acute intermittent porphyria, this profile may mimic acute intermittent porphyria, right, but the basic theme is same. Again in variegate, enzyme deficiency, protoporphyrinogen oxidase, the corresponding products are accumulated and excreted in urine. Urine is again colored, feces is colored, clinical symptom photosensitivity. Then this porphyria is actually very rare, right, and the other symptoms actually may vary. Therefore, this porphyria was named variegate, that is differential symptoms. Again alcohol and other drugs can aggravate the condition. And lastly, erythropoietic protoporphyria due to deficiency of ferrochelatase enzyme, there is excess protoporphyrin 9 and again excretion of protoporphyrin 9 in feces and other precursors in the urine are normal, right. Clinical symptoms again photosensitivity, major symptom liver cirrhosis, anemia, right. So, this chart basically shows what is the inheritance, how it is, what are the enzymes that are deficient. So, this is basically the same thing that has been repeated in the previous slides, but in a tabulated manner. You can actually pause and take a snapshot, so that will help you to remember the diseases easily, all right. So, all the porphyrias have been summarized here, and same the laboratory findings, that is what are the intermediates that are getting accumulated in specific type of porphyrias. It is already very easy for you to actually write it on your own. Just note what are the steps where it was blocked, and you can easily get the inference what are the things that are raised in plasma and what will be excreted in urine, right. So, there is also a variety that is known as acquired porphyria, which mimics enzyme deficiency that happens mainly due to lead poisoning. Lead actually inhibits the enzyme ferrochelatase and aldehyde, and the corresponding symptoms that are actually belonging to those porphyrias, but that is not inborn, not gene deficient, but due to poisoning, that is lead poisoning, are known as acquired porphyrias. So, acute intermittent porphyria is variety of acute porphyria, because the patient presents acutely, sudden. Yesterday the patient was normal, today there is acute abdominal pain, right. So, not only acute intermittent porphyria, the three varieties of porphyria that are considered acute are actually acute intermittent, variegate and hereditary coproporphyria, as well as ALA deficient porphyria. So, these four are actually comprising of the similar features. So, they are known as acute porphyria, whereas chronic means symptoms develops very slowly. So, what are the chronic varieties? X-linked dominant, congenital erythropoietic, porphyria cutanea tarda and erythropoietic protoporphyria. Along with these, the variegate and hepatic cutaneous porphyria or hereditary coproporphyria, sorry, are also having manifestation of skin. So, they are also known as cutaneous porphyria. So, as I told you, there can be multiple such classification, and you can actually place some of these in multiple classes. So, depending on the multiple choice question, there may be an all except type of question from all these varieties of porphyria. So, we can see this is again the chart of porphyria. We have added a new table where all the skin porphyrias that are having skin lesion or acute attack have been shown here. So, how we can diagnose porphyria? Already told during diagnosis of acute intermittent porphyria, that is we need to diagnose the intermediates in urine. Okay. So, for acute attack, what samples we need to collect? Porphyrins, and if these are abnormal, then these are actually also tested in 24-hour urine sample. And to distinguish variegate and hereditary coproporphyria, porphyrins are tested in feces also, right. And for cutaneous porphyria, urine and I mean whole blood and urine are also tested. And enzyme testing such as porphobilinogen deaminase may be done to detect latent porphyrias, okay, because that is the most common porphyria. How we can diagnose? Diagnosis is very easy by UV, not only by laboratory estimation. If we detect UV fluorescence, I mean if we transmit UV light, we can get a specific peak. We will be discussing it very soon. Next, Ehrlich's aldehyde reagent test. It is very easy to see, basically we mix the urine with an aldehyde, and depending on the presence of porphobilinogen or urobilinogen, a colored pink color urine positive, if it is formed, it gives rise to the suspicion of porphyria, acute intermittent porphyria, and that is also insoluble in chloroform, right. So, when urine is absorbed in ultraviolet light, if porphyrins are present, it will emit strong red fluorescence. So, we are almost at the end of our lecture. So, I discussed that is UV fluorescence. So, what is UV fluorescence? There is a term known as Soret band that is actually formed when we expose the urine or the sample to UV range of light. So, what happens? In specific peaks, specific porphyrins have got their absorption maxima. So, they give this characteristic band that are known as Soret band after the discoverer Jacques Louis Soret. Okay. Heme does not possess this property, it is only the intermediates who possess this property. Now, you know, there have been mythical stories regarding vampires that have got very common features like porphyria. So, sunlight sensitivity, you know, vampire skin burns with sunlight, they have got pale skin due to anemic, they have protruding and red teeth, they drink blood due to erythrodontia, and due to some unknown reason patients of porphyria, especially congenital erythropoietic porphyria, have got garlic allergy, which is again a symptom of vampires, right. So, basically congenital erythropoietic porphyria, since it is autosomal recessive, it was not found everywhere, only few members of the family had this vampirism disorder, right. And lastly, to treat, basically symptomatic treatment with IV fluid, glucose injection, hemine injection, that have already been discussed to alleviate the acute symptoms, and the definitive therapy is gene therapy, by which you can replace the dysfunctional gene to code the proper enzymes, but that is still under trial in non-primate human. So, this is the final slide where you can see the pathway that is of heme synthesis, that partly occurs in the mitochondria and partly occurs in the cytosol. All the enzymes in abbreviated form and their corresponding porphyria have been shown. So, it is very important that you draw this pathway on your own, and by now you should already know what are the abbreviations and what are the specific porphyria. So, to conclude, we have discussed the pathway of heme synthesis, what are the defects of heme synthesis pathway, specific enzymes that leads to these porphyrias, how they are inherited, what are the symptoms, what are the mechanism of porphyria, how we can diagnose and how we can manage the porphyrias. So, these are my references, and I thank you for your kind attention.